Welcome back to Analyze with Casey. Let me tell you a story. It's 2 a.m. in the emergency room. The air smells like alcohol swabs and old coffee. The hallway light is flickering like a scene from a medical horror movie. And you're halfway through your third shift in a row. In walks a patient. We'll call her Mrs. Garcia. She's hunched over, cradling her abdomen like it's going to explode. She hasn't had a bowel movement in 5 days. Her stomach looks like she's hiding a watermelon. She's sweaty, pale, and in obvious pain. The doctor glances at the screen and yells, "Get me an abdominal series, stat!" Now this is where the difference between technologist and technician comes in. You could just hit the button and pray, or you could slow down, position her right, set the correct technical factors, and catch that subtle sign that changes everything. By the end of this video, you'll know exactly how to do that. So let's take a deep breath in and start from the top. Before we touch the X-ray machine, let's talk anatomy. The abdomen is divided into 4 quadrants. Let's say that again, 4 quadrants. Draw a vertical line through the belly button and a horizontal line through the waist. That gives us your right upper quadrant, your left upper quadrant, your right lower quadrant, and your left lower quadrant. Now what lives where? In the right upper quadrant, you've got the liver, that big dense organ that loves to hide pathology. Underneath that, the gallbladder, a small but mighty organ, can throw a temper tantrum in the form of stones. Move to the left upper quadrant. That's where the stomach sits, often filled with gas that can fool you into thinking there's free air. Behind the stomach is the spleen, fragile and easily injured. In the right lower quadrant, you'll find the appendix, small, quiet, but if inflamed, a ticking time bomb. This cecum also hangs out here. Over in the left lower quadrant lives the sigmoid colon, which is a frequent site for diverticulitis, and loves to show up when you're off on a weekend shift. But wait, there's more. Behind all of this, you've got the retroperitoneum. That's home to the kidneys, pancreas, and the aorta. On your image, if you see faint outlines of the psoas muscles next to the spine, great. If they're missing, that could be a sign of hemorrhage, abscess, or aneurysm. Let me repeat that. Missing psoas shadows equals retroperitoneal red flag. Anatomy is your map. Know it well. It'll guide your eyes before you ever need a radiologist. All right, back to Mrs. Garcia. We're going to have her lying on the table, and we'll start with the AP supine, also called a KUB. Let's talk through this step by step. You position her flat on her back, arms at her sides, legs straight. Central ray goes to the iliac crest, which for most patient lines up with the belly button. You say, take a deep breath in, and now breathe out, and hold it. Why expiration? Because it drops the diaphragm, relaxing the abdominal muscles, and spreads out the gas for better visualization. Now for technical factors. Your SID is always 40 inches. Your OID is minimal. That's because she's lying right on the image receptor. Your KVP is set between 70 to 80 for average patients. If you have a larger patient, you may want to bump that up to 85. Your mass is moderate. You should use your technique chart. Always use a grid. Scatters everywhere in the abdomen. If you're using AEC, go with the center detector. If not, manual technique works fine. Just adjust for BMI, pathology, and age. Check for psoas shadows. Are they there? Kidney outlines, sharp or blurred? Bladder, visible? Diaphragm, clipped or complete? Symphysis pubis, included? If anything's missing, repeat it. This image is your foundation. Don't rush it. Now let's move to the AP upright. If Mrs. Garcia can stand or sit upright safely, we want to take this view next. Why? Because air rises, and upright positioning is how we catch air fluid levels and free intraperitoneal air. We raise our central ray to about 2 inches above the iliac crest. Ensure both diaphragms are included. We keep our SID again at 40 inches. But since she's no longer right against the board, our OID increases, which means we may see some magnification. To compensate, increase your KVP to 75 to 85. You may want to possibly raise your mass as well. Always use a grid. Ask for expiration and remind her gently she may be uncomfortable. Now, what are we looking for? Air fluid levels in the intestines, a black crescent of free air under the diaphragm, shifts in organ position or loops of dilated bowel, and again, markers, anatomy coverage, and exposure quality. Don't forget to include both diaphragms. Clipping them defeats the purpose of this projection. Now, what if she can't stand? That's where the left lateral decubitus comes in. We roll Mrs. Garcia onto her left side, place a sponge behind her back to straighten her, and give it 5 to 10 minutes before we take the shot. That gives free air enough time to rise. Why left side down? Because the liver's on the right and free air will float and appear against its solid border. If you do a right down decube, that free air could hide behind the gas bubble in the stomach and you'll miss it. Your SID is always 40 inches. Your OID is higher here, so we bump the KVP to 85 to 90. Always use your grid. Your horizontal beam is going to be centered 2 inches above the iliac crest. On expiration again, and then you're going to label this as LLD. Place your side markers clearly and look for a crescent of free air above the liver. We're looking for stacked air fluid levels in this image, sharp diaphragm edges. Now let's say Mrs. Garcia is in spinal precautions. You can't move her. Enter the dorsal decubitus. Leave her supine, laying flat on her back. Stand the IR next to her side. Use a horizontal beam to shoot across her body. You're using the same 40-inch SID. You should expect the maximum magnification due to the high OID in this image. You should also raise your KVP to 85 to 90. Always use a grid. Shoot on expiration. Look for posterior air collections, fluid layering, your peritoneal findings. Label the image dorsal decubitus. Mark it well. These images are crucial when patients can't be rolled. Let's talk image quality and digital processing. Once you take the image, your system applies a histogram, converts analog signals into digital by using ADC, and then uses a lookup table or LUT to refine brightness and contrast. It might also apply edge enhancement, smoothing, or equalization depending on the system. But here's the truth. Bad input equals bad output. So check your exposure indicator, contrast, noise. Graininess means underexposure. That's quantum mottle. Check for motion blur from breathing or poor timing. Look at the sharpness. Can you see bowel walls, psoas lines, and organ edges? Let's do a quick case review. Mrs. Garcia's supine view shows dilated loops of small bowel, more than 3 centimeters wide. There's no gas in the colon. On her decubitus image, air fluid levels stacked like pancakes, but no free air. Diagnosis? Small bowel obstruction. Now imagine a second patient, 30 years old, walks in holding his stomach, sudden pain like a stab. His upright x-ray shows a small, thin, black crescent under the right diaphragm. That's free air. He has a perforated ulcer. It's time to call a surgeon. Crescent of free air is a likely perforation. Air fluid levels usually equal obstruction. If there's no gas in the colon, they may have a distal blockage. If you have a dilation of the bowel larger than 6 centimeters, that's a sign of toxic megacolon. Learn these patterns. They are tested, they are real world, and they matter. But wait, let's make this trickier. What if Mrs. Garcia's x-ray showed thumbprinting in the colon walls? Those soft, scalloped edges aren't just shadows. They're a sign of ischemic colitis, where blood flow to the bowel is compromised. The ARRT loves testing this. Or imagine her supine view revealed a coffee bean sign, which is a twisted loop of colon that looks like a Java state. That's a volvulus, a surgical emergency where the bowel twists on itself. And here's a curveball. What if her upright views show calcifications in the right upper quadrant? You'd need to decide, are those gallstones, kidney stones, or are they harmless phlebolyths? Look for the rim sign. Gallstones often have a dark outer edge, while kidney stones align with the ureter's path. Let's break down 5 ARRT must-know pathologies. 1. Toxic megacolon. This is when the colon is greater than 6 centimeters wide, and it looks like mucosal thumbprinting, and the patient may have a clinical history of irritable bowel syndrome. If you see this, the patient is hours from rupture. Number 2, pneumatosis intestinalis. Gas in the bowel wall. This looks like bubbly chains. It's either benign, you can see this in COPD patients, or it could be deadly if they've got bowel ischemia. Number 3, appendicolith. A calcified stone in the appendix. Pair this with right lower quadrant pain and its appendicitis until proven otherwise. Ogilvie syndrome. Massive colon dilation without a physical obstruction. This is common in ICU patients. 5th, retroperitoneal hemorrhage. Missing psoas shadows and a patient on blood thinners, that's a code red. These aren't just test questions, they're landmines in real practice. Now, let's talk equipment failures, because the ARRT will test you on this. Say your images have herringbone artifact. These zigzag lines that look like a fish skeleton. That's a grid error, usually from incorrect SID or a tilted grid. Fix it by rechecking your distance or switching to a focused grid. Or maybe your image has ghosting, which is a faint duplicate of the anatomy. That's a CR plate erasure error. Run an erasure cycle and repeat the exposure. And if your AEC keeps overexposing obese patients, override it. Use manual techniques, 85 to 90 kVp, high mass, and a grid. ALARA still applies, but diagnostic quality comes first. What if Mrs. Garcia has a colostomy bag? Here's the ARRT approved method. Leave the bag in place, do not risk leakage, shoot through it, but increase kVp by 5 to 10 to penetrate the plastic. Annotate colostomy present in your tech notes. Or, if she's geriatric and bedridden, use the dorsal decubitus view with a horizontal beam, place the IR in a vertical holder to avoid grid cutoff, increase exposure time to 50 to 100 mass. Frail patients breathe slower. Increase exposure time to 50 to 100 milliseconds. Frail patients breathe slower. Behind the scenes, your machine needs love too. ARRT expects you to know daily QC. Check your collimator. Your daily QC, or your daily quality control, you have to check your collimator alignment with a star test pattern. Monthly, you need to test your AEC consistency using an acrylic phantom, and yearly, you need to calibrate the kVp with a penetrometer. Fail these, and your images could lie to you. Let's wrap up. Abdominal x-rays tell stories. You just have to know how to read them. That faint line, a missed perforation, that clipped diaphragm, a misdiagnosis, that forgotten marker, a legal nightmare. So slow down, get it right, because your image might be one that saves a life. If this video helped, hit like, subscribe, and check the quiz link below. Next time, we're diving into contrast studies, barium swallows, small bowel series, and how to follow the flow. Until then, keep your technique tight, your markers clear, and your collimation tighter. I'll see you in the next one.